started. So thank you very much and welcome to another BeSST Show and Tell. I'm going to let the presenters introduce themselves. We're delighted to hear to be able to hear a bit more about a similar-ish organisation and the work that you've been doing around medical sociology, particularly within the curriculum in Germany. So really happy to hear more about that. So I will pass over to you. You can share the slides and also introduce yourselves.
Thank you.
Thank you, Jenny. Yeah, just a second until it's here. Yeah. So, hi everyone. Thanks for inviting us or giving us the opportunity to share what we are doing here. So my name is Lena, and I prepared the slides together with Tamara. So, who are we? First of all, maybe I'm a professor for medical sociology here at the Faculty of Medicine at the University of Cologne, so in the Midwest of Germany, almost in the Netherlands. And I'm part of the Faculty of Medicine, and I'm working at the Institute of Medical Sociology, Health Services Research and Rehabilitation Science. So we do lots of research and teaching in the field of healthcare. And at the same time, I'm currently involved in the German Society of Medical Sociology. That is the key organization of all people that do teaching and researching in medical sociology. I know that also Simone is here. She's joining for the first time today as well. She's from the university next to Cologne, which is Düsseldorf, and she was also part of the board of the German Society of Medical Sociology. So she might be able to add a few points in the end. Tamara.
Yeah, I'm Tamara, and I'm the postdoc of Lena at the Chair of Medical Sociology. I just written down that I have been a digital visiting scholar in Edinburgh, and I'm super happy about the invitation.
Yeah, this is how we came to BeSST, because Tamara got to know Martin Pickersgill in Edinburgh, and he recommended to get into contact with Jenny. Yeah, so thanks. Thanks to Martin. So first of all, we are doing medical sociology here. We're teaching and doing research, but we are in between two faculties. We are officially at the medical faculty, but our institute is a bridging institute. So the institute has one pillar of the bridge is in the medical faculty, the other one in the human sciences faculty, which is a bit specialty probably of our institute. So we are between two worlds, sometimes at least. What we also have is a tri-faculty center for health services research. So we are not only involved in two faculties, but actually in three, because we also do shared research with the faculty of business and sociology, something like that, I think it would be translated. So we're really trying to do interdisciplinary teaching and research. And at our Faculty of Medicine, where we mostly are involved, we are also involved in a cross-sectional research area that has the name Health, Person and Society. So why do I show you this slide? It's just here to show you the interdisciplinary nature of our institution and of what we are doing. And what we thought could be a good agenda for today is a short introduction into the medical sociology community in Germany, and also into the medical curriculum and where medical sociology is located, let's say. And then Tamara will take over to show you what exactly we're doing in teaching medical sociology here. Maybe let's start with a very short history of medical sociology. I won't go back into the ancient history, but the more modern history of medical sociology, because it's important to know it builds the basis of what the community is like now today. So between 1960s and 1970s, medical sociology developed from more informal to a more formal scientific discipline, let's say. So before 1960, there were individual people doing research in the field of medical sociology, However, they haven't been organized, so they just did what they found interesting. So after that, they started to form a more scientific, more organized discipline maybe. And as you can see in the title, I'm talking here about the Federal Republic of Germany, excluding the developments that happened in the DDR, in the, what is the term in English? German Democratic Republic, I think is the English word for it, because it's a bit too complex to show you both developments. But there is a quite interesting story about it. It is written down on our website of the society, so if you want to translate it into English by using any AI software, feel free to, if you're interested in that. So then in 1970, one very important thing happened that led to the formalization or to the institutionalization of medical sociology in Germany. A new licensing regulation, or here it's called approbation, for doctors was released. And this, for the first time, included psychosocial competencies in the medical curriculum. So this was new at the time. And it also introduced for the first time medical sociology and medical psychology as disciplines within the preclinical study phase in medicine. And this was like the starting point of building a community around medical sociology. And this is also the reason why in Germany, predominantly medical sociologists are working within medical faculties, because the training of medical students required people to teach medical sociology within medical schools. So between 1970 and 1990, around 14 full professorships were installed for medical sociology in Germany. So this was the starting point, I would say, for these kinds of professors. In Cologne, I just put into brackets, it was a bit later that in professorship what was introduced was in 1997 that the first professor here was installed. And shortly after that, that gave the basis for founding the German Society of Medical Sociology, because like people needed a voice, like a, how do you say that, a common voice that speaks for the community now that there are more professors and curriculum that required our discipline to become active. And then shortly after that, it was at least written down that medical sociology was being taught at almost every medical school, but not always by a professor. So it's still the case that we've got lots of medical faculties that do teaching in medical sociology because they have to, but they don't necessarily have a professor or someone who is really like part of the community. Then shortly after this, in 74, the first state exam also examined the discipline of medical sociology for the first time, let's say, and until now it's still the case that we are involved in the exams. And by around 78, 79, it became like obligatory to really have courses at every medical faculty in our field. But still, medical sociology had to fight for its existence, like in these times, because it was hard, as you probably can imagine. It might be the same in other countries, that there was a lack of acknowledgement of our disciplines within the medical field. There was just no real understanding of why should you have a sociologist within the medical school and why should you look into the social spheres. And the same somehow applies to a lack of acknowledgement by the real, let's say, the real sociologists, the ones that are not within the medical faculty, but within the faculty of sociology. So there was a struggle on both ends. And since 1980, so first a few new professorships were installed, but at the same time, shortly after that, a few were already being abolished again, because of like power struggles and so on. And teaching was sometimes taken over by other related disciplines, like psychology, for example. What is the situation like today? Medical sociology still has to be taught and examined, so it's still the same requirement mostly. I would say I don't really know the numbers, but I would say that about 1/3 of all medical schools in Germany have a professorship for medical sociology. The community is small, but it's active in teaching and in research. The integration within medical schools, I would say, is okay. It could be better, I guess, in terms of acknowledgement and research and so on, but it's okay. I would say people have accepted our discipline and also value our discipline, I would say. Sometimes it's still challenging. We still have quite a distance to the sociological community, just because it's in another faculty. It's a bit of a distance, I would say. Our Society for Medical Sociology, in terms of memberships, it's growing. So we interpret that as a good sign, so that more young people join our society. And we've got an annual national conference where we present our research and get into exchange. And we also got close ties with related fields. There are more, of course, there are more fields that are interested in the social topics around medicine, which is social medicine, prevention, public health, and so on. We have established quite close ties, and that's really helpful to work together on many elements of our agenda. And this is just showing you the development of members of our society. It's nice to see that it's growing and not decreasing, and there are a lot of PhDs and lots of young people joining our society. I also wanted to let you know that the next conference from the European Society of Health and Medical Sociology is taking place in Hamburg in Germany. It will take place next year in August. Like colleagues of us are trying to organize it. It's Olaf von dem Knesebeck who's taking the lead. So I think it's still possible to submit abstracts. I think the deadline for submitting symposia has ended, but abstracts I think are still possible. So you might see some of you there, maybe. That was the history of medical sociology in a nutshell. And now at least a few words about the medical curriculum and how medical sociology is integrated. So I did a screenshot, it's in German, sorry, of the old approbation regulation in medicine. And this defines on the left side the topics that have to be taught in the preclinical study phase. And with the red arrows, you can see it's medical psychology and medical sociology. We've got to have a lecture course and also a seminar on both topics. And on the right side, you see the exams. So that is the content of exams. We have to have at least 60 single choice questions in this case that have to be part of the state exam. So we have that at least. That's the minimum requirement that medical faculties have to work. And also then there's a national curriculum. It's a kind of a recommendation for all medical schools, and they should somehow adhere to the national curriculum. However, it's not strictly binding to do that. There is a website, but it's of course all in German, so it won't be very helpful for you, I guess. On the right side is just a screenshot of a small part of the content in there. So it defines learning goals and topics, and also it defines, or it gives a recommendation of which discipline should be responsible for which topic, kind of. This has been worked out by many involved people. Like all the disciplines have been involved in doing this, and there have been some reforms going on in building the next version of it to have a more modern curriculum. What we as the Society of Medical Sociology did is we constructed our own core catalog in medical sociology and teaching, and I just wanted to show you at least the headings of it. It might be interesting for you to see what is in our core catalog, and we just give it as a recommendation to medical schools. It's no requirement to fulfill all of that. To fulfill all of that, it's just a recommendation. So the first part would be theories and methods. in the sociology of health and illness. This covers lots of broad theories, but also quantitative and qualitative empirical methods. A second part would be the social production of health and illness. This covers a lot of topics like work and health, gender and health, demographic change, of course, social inequalities, and many topics more. The next point would be the German healthcare system. We also try to give an overview about how the healthcare system is functioning and about social inequalities in healthcare. And patients and physicians and their roles within the healthcare system, and also, for example, the sociology of health professions, doctor-patient relationships, sociology of disability, and all these topics. And last but not least, health promotion, prevention, and rehabilitation. So this is our minimum requirement, we would say. So on the right side, you can see these are all medical faculties that we have in Germany. The red dots, I think it should be 43 if I'm not, should be the right number, I hope. And these 43 medical schools have to fulfill a minimum set of requirements that I just showed to you. But 10 of these medical schools are, they have a bit more freedom in creating their medical curriculum, because they are so-called pilot curriculums or pilot places where they can involve innovative elements into their curriculum to just test them so they can divert from it a bit. This includes, for example, Cologne, but also Düsseldorf. So what innovations are in there or are being tested is, for example, a stronger integration of the preclinical and clinical study phase, more learning spirals, problem-oriented learning, an early patient focus, and not only talking about the basics of medicine, but early on have an integration of patients. And last but not least, a longitudinal track on scientific basics. And these model projects should be evaluated, and the knowledge from these projects then went into the recommendations that you can see on the right bottom side, recommendations for the development of medical education in Germany. So this was, this recommendation was, it builds a bit on these pilot projects. But they're still running, so they haven't been finished, they're still running. Last but not least, this is my final slide until I hand over to Tamara. There have been some reforms ongoing, or at least we tried for many years, but in the end it didn't work out. So I think Simone was very involved in this. Probably now it's maybe something like 12 years ago that it was decided to have a new curriculum and to renew the approbation or the licensing regulation. But in the end, many people were involved and worked towards this goal, but it didn't work out because it would have cost too much. This is the easy explanation, I think, for it. In the end, everything was stopped, and now we are back like it was 10 years ago. So it's very frustrating that it's like that, but still the faculties try to do some new things and to integrate some innovations. All right, I'm handing over to Tamara.
Thank you. So I just want to give you a quick insight in our teaching in Cologne and what are somehow opportunities we see for the medical sociology in Cologne, but also beyond in Germany, and the challenge we faces. So we have a very interdisciplinary focus, or we are based in different faculties. One is the medicine, where also students from health service research and health economic are part of our lecture series. We have the medical sociology introductions and seminars, which take place in the first semester, and the lectures on health promotion and prevention, which is the 10th of semester. Then we teach in midwifery science on prevention and family health, as well as health service research. This is a master program, an interdisciplinary one, where we actually at the moment teach on qualitative research methods. And our goal within these different disciplines is really to improve our status as a medical sociology, and really in particular in medical studies to show why a perspective from medical sociology is important. And this is sometimes quite challenging. Maybe we also can discuss that later on. And we are focusing now on medicine because I think it's a good example to show how difficult it sometimes is. And within our teaching and also the given role we have as a sociologist at a medical faculty is that we want to have a research-based teaching, meaning that we really want to show students how to do research and to think scientifically. We try to be applicant-oriented, meaning that we have the experience. It is very helpful to really get practical and not too theoretical to show the importance and also the use of medical sociological perspectives. Therefore, also student-centeredness, as well as a way of develop a critical thinking is for us quite important, as well as openness from an interdisciplinary point of view, because I think this is quite important for them also in future, the students, the medical faculty. As I said, we have this different phases where we get in contact with medical students. It's the first semester with a medical introduction, and I will tell you in short a bit about the content and the seminars in the 10th semester. And if students would like to explore further medical sociological perspective, they also can do a scientific project at the chair where they somehow get the opportunity to do a research project before they start their doctorate. So what do we teach in the first semester? I don't read everything out, but I give you some examples. We have the question of what is medical sociology, over demography, patient and doctor interactions, preventions, and the bigger picture, maybe also the healthcare system, as Lena already pointed out. Beside this lecture series, we have a seminar series where they have the opportunity to conduct a research project they choose. So what is the research about? So we have like 6 sessions, 3 hours. These are smaller groups of students, and our goal there is really that they learn how to conduct qualitative or quantitative methods. And on the right, you can see some posters out of it, which can be like a result of that course. And the course is quite tough because it's a time frame of 6 sessions. So in the first, they learn to formulate a research question and to develop a research design, doing a literature review. The second, they already start collecting or conceptualizing the research instruments for example, interviews or questionnaires. And the third, data collection, while the fourth and the fifth is data analysis, and also the question of how to present research results via a poster, while the sixth they presented. So it's a time schedule which is sometimes demanding, but I think it's very great to see how the students manage their first contact with research in a medical sociological field. And the second time we get in contact with the medical students is on prevention and healthcare promotion. Here we are focusing much more on prevention, different forms of prevention, patient safety, but also a question of public health interventions. Again, also the bigger picture of the perspective of medical sociology. So we wanted to bring you some feedback students gave us, starting from where it went very well. Where one person said the lectures were engaging and easy to follow with a pleasant and interactive atmosphere. I found the topics, especially health policy and population level prevention, particularly interesting. So that was quite nice to read. Some told us about the quality of the detailed checklist and that there are a lot of self-assessment questions which they found very helpful. But of course, there are also some perspectives which are more demanding for us also to see how different students can perceive our teaching. So someone said, overall, the course provide a solid foundation in prevention. However, the effort expected for many exam questions seemed proportionate to the practical benefit for medical students. So really also the question of how can we really get students to see the importance of our courses. And finally, sometimes there are not so often feedback like this, but we also wonder where the frustration comes, where someone said, what is the purpose of this module? Is it your goal each semester to show medical students how theoretical and practical and essential unnecessary prevention and healthcare promotions are? So it's quite difficult for us sometimes. And in order to adapt and also really to reflect on the different feedback and to provide a very good practical teaching. We have like reflection sessions where each lecturer in medical sociology come together. We talk about our experience, analyze student evaluation, think about concrete ideas for adjustment, and really use a space of critical and constructive feedback to improve our teaching. So there are, as I said, some challenges. We see sometimes it's hard to convince students of the importance of medical sociology for their professions, in particular if they are from the first semesters, because they haven't got in contact with patients, and sometimes the social aspects are not clear in the first semesters. But it can be also a chance, of course. We have the problem of attendance within the lectures. So the students don't have to be there, and it's quite demanding to really help students to engage in critical and sociological thinking. And if they aren't there and just learn the texts we gave them, the material, it's quite hard to really show what is important, and we sometimes wonder who is coming and who's leaving out. So that's sometimes demanding. We also have the bigger picture at the medical faculty, while we try to really also engage with other disciplines within the medical faculty to show the importance of medical sociology. We find being in different formats, getting to know other professions are super helpful, really to show what we have to offer. And Lena already told you about the distance and the question of we sometimes have the feeling that we are not, we have a critical position as the medical faculty as well as in sociology. So these boundary works are sometimes demanding, and would be super interesting to discuss that with you. In the end, some things that help us, which were teaching corporations, for example, with medical psychology, who faces the same problems as we, but also like we're connected to gender studies at our campus, with some organizations, some form of NGO, maybe we can call it like that, Solidarity Medicine, and also with other internationals. And we're, of course, super happy to get to know you now, and would really like to connect with you further beyond this day. So we're coming to our outlook, and I would...
Yeah, just maybe to sum it up, what we already said, and maybe to introduce the discussion. So in Germany, medical sociology is luckily part of the medical curriculum, which is really good. It helped to build up the discipline and to institutionalize it. However, like maintaining or safeguarding the discipline always remains a critical task, at of our Society of Medical Sociology to. So we always try to be in discussion with faculties about whether the professorships are being maintained or not, and all these political discussions. And medical sociology, as part, like being a medical sociologist as part of a medical faculty, has its pros and cons. Sometimes I think it's really good if you want to change the medical system, you have maybe you have to be part of it to change it from within, but it might also be helpful sometimes to be just outside of it, to have a more critical view. Something that would be interesting for me to discuss, I think.
Yeah, and I also wanted to add the question of where medical sociology in the medical curriculum is situated best, how and when, because we see, for example, teaching it in the first semester has also some pros, as they are not so much in the natural science positivist thinking, and really can get to have a start with them, while later on they really appreciate much more the sociological knowledge production and how they can really practice it in situ. So that is a point we're really discussing a lot. And finally, also the question of how to be present at the faculty, building up interdisciplinary cooperation, which we find is the key to institutionalizing further medical sociology. And I think that's something which was at least, or is for at least for us very helpful. Yeah. And finally, thank you so much for listening. Yeah. And we would unshare now.
Thank you so much. That was really fascinating. It's just really interesting to hear what's going on in Germany, and from your perspective, what you're doing, but also what are the challenges, and also the bit of history. There's a lot of parallels. I'm sure if we did a deeper dive into the history, there'd also be points of difference at what happens at what particular times in terms of the wider contexts. But I think that the challenges are certainly things that we have talked a lot about within BeSST and within the UK. I've got a long list of things I could ask about, but as chairing this, I'm not going to hog it, so I'm open it up for other questions or comments. Anybody want to jump in first? Heidi.
Yeah, thanks very much. That was really interesting. And like echo what Jenny said, hearing lots of similarities between the kinds of conversations that we might have here, which is sort of both comforting and not comforting at the same time, I suppose. I was just interested to know a little bit more about the research projects that the students do that you were talking about. I'm just curious to know what kinds of, do you give them topics, or do they have some choice there in what they get to do? And I'm kind of curious to know what things do they show an interest in and want to be studying? And sort of as part of that, what's their orientation to the qualitative approach? Do you see some of them engage with that?
I just start, and Lena can jump in. So in regard to the research topics, it depends on the person who would like to be the supervisor. Often we gave them a direction. So a lot of lecturers give them like literature reviews. I also have made some codings with students, so they really get to know quantitative theory or content analysis. And the students who observe that are always super happy about that, because they say, this is so interesting. And sometimes they also say they are starting to having a personal crisis because they see how good sociology works. And sometimes other courses are much more difficult for them, and or less interesting. And I think that is quite nice also to see and to show how a doctorate could look like, and to get to know the students, because if they are really into medical sociology, sometimes they come back to write their doctoral thesis at Lena's chair, which is nice. And you also said the qualitative approach. So I am at the moment the only person teaching the qualitative seminars, but I really like it because I think it's important to show that not only statistics have a value, but to show how techniques of having question, reflection on perspectives gives them an insight into other forms of knowledge they would not gain through, for example, questionnaires. But of course, it's not so much time. So not every student is like happy about it, to be honest. Yeah.
Yeah, and in the seminars, the 6-week seminars, we got these groups of 20 students, and if they come to my lecture, so they can't choose, they're just distributed to us, let's say. If they come to my seminar, they will have to develop a survey, and it somehow has to have a relationship to the wider field of patient surveys, for example. And then they develop a question that is related to medical sociology, so related to my topics of the lectures. And then they can freely develop a topic, do a little bit of like a literature review, but only quickly because we don't have the time. And then they have the freedom to recruit patients at the university clinic. And they can also, so we've got an ethics vote that applies to all of our seminars. And they have the freedom to contact wards, for example, and to say, okay, can we maybe try to get 30 patients within the next week to give them our survey, for example. So, and they really value that a lot because they get into contact with patients. They can knock on the door and ask patients, okay, would you have 5 minutes to fill out my survey?
And I forgot also the second part of the question, the topics. So in the seminar, we let them choose the topics, and they also get the opportunity to give us feedback on the content of our lectures. And we see, for example, gender-sensitive medicine is a highly important topic for them. So they ask about it, or in each course or seminar I teach, I have at least 2 projects from groups who work on different aspects of gender sensitivity. I think that's quite a thing.
Yeah, they have an awareness, I think, for like inequalities in general now. It always depends on the cohort, I think. A few years ago it was a bit different, but now I think they have good awareness. Sorry for the long response.
No, that's really helpful. I'm probably slightly jaw-dropping that you should be allowed just to go around recruiting patients. There's just no way. That's one of the hurdles that we face is the ethics
we
barriers. Because I don't mean that in a negative way. I'm fully on board with ethical oversight, and I think we have had times in the past where it's been, for student projects, it's been a lot looser here and with much less oversight, and I think that's been potentially problematic given the fact that they're very novice researchers. So, and allowing students to go out to do interviews or design surveys on sometimes very sensitive topics, I think is slightly problematic, and so I'm quite in favour. But it's finding that balance. But that's really interesting to hear the approach there.
That's true. We discussed that a few years ago with the ethics committee because we told them, okay, we want people to make the experience of how is it to really collect data and so on, and therefore we have some requirements to fulfill. So, but this is easily done. So they tell us, for example, okay, we have this like general ethics vote for you, but the requirements, for example, include that you only are allowed to survey patients from the University Clinic of Cologne, and you can survey students and workforce and so on. So they did some requirements, but it works quite well.
Yeah.
And we also, I think, limit, of course, the topic in that sense. If it's too vulnerable groups, or if we have the impression that it's too delicate for young students, and also for the person they would like to talk with or conduct research on, we always try to find alternative topics.
Yeah.
And
Yeah.
often they also choose like medical students or physicians and the role of organization, which is also
Yeah.
like.
Simona, you wanted to comment on that as well, or is it a different question?
No, I would like to ask, how many students do you have, Lena and Tamara, and you guys? Because I think the student number is always a limiting factor.
Yeah.
So we have been discussing about research projects, little research projects in the last years, and we always came to the point that we said, so we have some 400 students every year. And it's the cohort is just too big to really do something like that. Tamara, how many students do you have in Cologne?
So it's kind of the same, Simone. So every half year, the students are starting. So every half year, 200. That would be 400 each year as well. But so we've got the lecture series and these seminars, 20 students per group. So we've got 10. We have 10 lecturers in parallel doing the same seminar. It's really a lot of work, but it works. And the other projects that they can do like on their own after that, like let's say a voluntary research projects, we have just a capacity, and if we can't give out more topics, then we don't. That's yeah.
And this is one-on-one mostly.
Yeah, this is one-on-one. Like it's a very small thesis kind of.
We do have in our second year, we have our students doing projects that are not officially research, because we try for exactly the ethical barriers in some ways, that the ethical oversight that's required. So it's more consultation, but they do that in groups. So we have about 320 students, but they do it in groups. But as the numbers have got bigger over the last 2 or 3 years, the groups are getting bigger, and they're becoming quite unmanageable. I think when they're working in a group of 8 or 9, it's really difficult for them to distribute the work and to work positively together. I think the issues around group working is problematic.
Yeah, maybe
that's always a challenge.
Maybe I should add that the groups of 20 students per seminar, we then divide them up into groups of 4.
Yeah.
So with small groups then.
I wondered if you could say a bit about you might not know because not everybody works in this way, but the sort of time allocation or the proportion of the course. So in year 1 or year 1 semester 1 even, what proportion of the course is allocated to medical sociology, and does that map on to the proportion, the weighting that it has within your assessment?
It's not the same. It doesn't really match in Cologne, at least. I'm not sure about Düsseldorf. So in the exams, we've got the same like amount of questions than, for example, anatomy has, although anatomy has probably 4 times the lecture times that we have. So kind of, but I think this is more an advantage for us, at least in exams, we are the same. Yeah, that's kind of about what it is. Yeah. So they've got anatomy, I think, through the first 3 semesters or something like that.
Is all the assessment through exam questions then? Is it MCQ type question? Yeah.
It is.
And has there been any consideration of other forms of assessment?
We've got at least, so we've got mostly the single choice questions, but also a few free text questions included. Only a few, I think 4. It's also, of course, a lot of work to check them then. But I don't think it's really been discussed. What we additionally have after the 4th semester, we see them again in the oral exams. So first they do the written exam, and then after the 4th semester, they do a practical oral exam. And there is this form of exam is really good, I think.
It's quite different. I'm just thinking compared to what we do in our first year. We have they write a report based on an interview with a patient. So it's drawing on the things that they've read and the work that we do with them in classes around understanding what it's like to live with a long-term illness. And they write that, and part of it's reflective, part of it's more analytical. So I think we've discussed a lot in BeSST about the challenges of relying solely on exam questions, because it's the nature of the subject, the nature of the discipline is much more discursive, and to demonstrate application and understanding is very hard to capture. We aren't ignoring exam questions, and we've actually got a group now that's working with our Medical Schools Council Assessment Alliance to create questions in these subjects, in our subject areas, both psychology and sociology, that would be suitable for our final exam, the medical licensing assessment. But it's not straightforward. But I think the general idea, I think, is that we need those, but we need other forms of assessment as well. So we'd be really happy to share that with you at any point.
That's really interesting. I think it would be really a benefit, although since the medical curriculum here is so highly regulated, it wouldn't be possible at the moment because it really states what kind of exams should you do. So it could be an additional thing, maybe, like an in-between exam or something that could work. But what do you do about the use of AI then when you're letting students like write reports?
Yeah, so that's obviously the more recent that's become an issue, and it's something that everyone's thinking about in terms of so for that particular assessment, we do advise the students that they shouldn't be uploading, because it's basically they interview a patient. They're not allowed to record it because of data protection. We don't have the permissions to do that. But they take notes. So we're saying what you can't do is upload your notes about the patient into an AI tool. So we make that really clear, and then they have to state how they've used AI, in what way, if at all, if it's like searching for concepts or literature or whatever. So we try to limit it, but that's not to say that they're not using it. But I think that they will be using it 100%. We know that they're using it, and I'm all up for that. I love ChatGPT. I think it's awesome, and I use it all the time. So they will be using it, and it's more working with them. But it is challenging. I think we have another essay that's an ethics essay that's a much more straightforward standard essay that's choose an ethical issue and write about it. That's absolute perfect fodder for AI, that it would just rattle off a whole essay in literally 2 seconds. But so that's more difficult. And in one other bit of the course on communities, health and communities, we have moved, and for some of them to move towards, they do a little mini presentation and then a viva. So that is something that we're thinking about expanding to. We've got 2 programs. One is a smaller program for healthcare professionals who are transitioning into medicine, and the other is the main program. And we've tried that for the smaller program, and whether we've got the capacity to do it for the bigger one. I think we do, actually, in terms of marking. It's more just the logistics of timing it is that's always a challenge when you've got lots of students. But those are the sorts of things thinking about. But it's interesting though, the difference, because the GMC, nothing to do with sociology specifically, but the GMC requires medical schools to have a range of different assessment tools. So they don't rely just on exams. They're actually requiring that across the whole programme that medical schools actually use a range of different assessments. So, and again, if you look at I'm just saying these are things that you could use as levers. There's the Ottawa Consensus on Assessment in Medical Education. That was John Norsini, I think, and he led on it. That's fairly recent. Again, they talk quite a lot about the benefits of using different kinds of assessment tools, and particularly the idea of not just assessment of learning, but assessment for learning. And I see that with my students when they write their report about the patient interview. The writing of the report is a way that they're processing the ideas and really reflecting about it. So it's not just that they have to demonstrate that they've understood certain things or acquired certain skills, but the doing of it is a learning process for them, that I'm not sure that I don't know how I would capture that with questions in an exam. So we used to try, and I gave up. So, but I
Yeah.
appreciate your context is really different. So it's not to say that this is not in any way any criticism of you, but just if any of that was useful, if you think you can pioneer and change the system, then we'd be really, really happy to help and,
Yeah, we'll
and
see.
have those conversations with you.
Yeah, therefore it's a bit a pity that this planned reform is not coming, at least not for the next few years. That would have been an opportunity to change things. Now it's more like every faculty is now trying to do small innovations in the curriculum by themselves, whatever they
Yeah.
can do, without violating the requirements, you know. So it's
Yeah.
more incremental, I guess. It's a bit
Yeah.
we're a bit stuck at the moment.
And in other faculties, medical faculties, we see, for example, in Bonn, where they also teach communication and with actors and actresses on how to talk to patients. And so I think this is also, this is there a medical sociology topic, and here we do not have the opportunity to do that. I think others do that.
We don't, but others do.
Others
in
do
Cologne.
that.
So it's here. It's part of the psychosomatics teaching, but not our medical sociology teaching. That's true. Yeah,
absolutely. And so it's quite interesting how also within the German system, different competencies are prescribed maybe to medical sociology, and also the range of what we can do and not is quite different. I don't know how it is in Düsseldorf. I'm throwing you the ball. I'm sorry, Simona.
You're on mute.
Dein Mikro, Simone.
You're on mute.
I'm just thinking about something different in this context. Sorry, what really drives me is to get more inequalities in the curriculum and more public health in the curriculum. It's a different topic now, but I wasn't following for the last 2 minutes because I was thinking about it, and again it's the limiting factor is the amount of students. So we have a very good prosperous situation here in Düsseldorf because we have a Center for Health and Society. That means we have different health disciplines assembled here. For example, the general medicine, occupational medicine, and health services research, and medical sociology, all in one large building, very new building. And there is a window of opportunity of interdisciplinary teaching, research anyway, that's fine, but teaching and with public health in the curriculum. But it's always the amount of students that limits it. So we have a good compulsory elective program where we invite homeless people to come to us, where we offer a limited amount of students the chance to get to know the health authorities in the community, to be there for 1 week and to see how doctors at the public health authorities are working. But it's always for some 10 students, some 20 students, and that's not really, that's not satisfactory. And that really drives me how we can overcome this. And so more poverty into the curriculum. Yeah, because our students are, sorry, just one sentence, our students are from the middle, in the middle class bubble, as your students are as well, I suppose.
I think we're almost running out of time, so I feel like there's so much more we could share. So I think we do need to after this, we need to have a bit of a think about how we do share a little bit more, because thinking about how you introduce health inequalities, there's loads of our members are teaching, loads of people involved in BeSST are teaching on that, including here at Edinburgh. with large numbers of students and different ways of doing it. And our last show and tell was people from Dundee who were talking about a community placement that they were running, that they are now scaling up to all of their students will have to do a service learning experience that is often rooted in discussions around health inequalities as well. So there are examples of things happening, but I completely understand the challenge of these things when you're managing it with that number of students. But there's lots of different, I think, good examples of good practice of ways that you can do it happening. So be really happy to think about how we can share that as well. In terms of the point you just made there about the nature of our students, again, I don't know within Germany, that's something else we could think about is deliberate policies towards widening participation. Within the UK, that has been a very, very deliberate move to broaden out the range of and the diversity of medical students in lots of different categories, but particularly thinking about socioeconomic status. And it's been incredibly successful in getting different students in. The profile of our students within Edinburgh has changed really, really dramatically within the last few years. So it would have been a very classical middle class group of students before, and it's really not now, not as much. So these things are happening a lot as well. I'm sure they are in Germany as well. I'm afraid I've come to the end of the time. I found this really, really interesting, and I think hopefully when we did talk before, but maybe we do some kind of joint conference or something that we could do that would be, I think, great to share ideas. But I really appreciate your time, and I'm sure lots of other people will be watching this with interest. So thanks again, everybody. I'm just going to stop the recording now.